Hello and welcome to the fourth installment of the Transplant C-Suite Snapshot Webisode series. For this installment, we're focusing on the Transplant Institute, a model for alignment and integration. We're pleased to be joined by Dr. Marwan Abouljoud as well as Mr. Robert Hawkins. Dr. Marwan Abouljoud is the director of the Transplant Institute in Hepatobiliary Surgery and is the Benson Ford Chair in Transplantation at Henry Ford Hospital in Detroit, Michigan. He's been with Henry Ford Medical Group as senior staff since 1994 and is the recipient of the Dr. Fred Whitehouse Distinguished Career Award. From 2013 to 2015, he served as Chief Medical Officer for the Henry Ford Medical Group and is also a professor of surgery at Wayne State University. Dr. Abouljoud serves as a director on the American Board of Surgery and is chair of the Diplomats Committee. Currently, he is president-elect of the American Society of Transplant Surgeons and is past president of Gift of Life Michigan, having served on the UNOS Board of Directors and was counselor for UNOS Region 10. Robert Hawkins is the administrative director for the Transplant Institute at Henry Ford Hospital. He's been with the Henry Ford Health System for 16 years, including directing the transplant program for the past 8. Bob has had a varied career in 35 years in healthcare administration, including positions with hospitals, physician groups, and with insurance companies. Among his areas of expertise include directing physician practices, leading hospital managed care programs, and guiding the strategic planning and operations of a large community hospital. Gentlemen, we're pleased to have you with us, and at this point, I'll turn it over to you to begin our program.
Okay, well, I want to welcome everybody to the Alliance C-Suite presentation here on the Transplant Institute, a model for alignment and integration. My name is Marwan Abouljoud, director of the Henry Ford Transplant Institute, and I'm with Mr. Bob Hawkins, who is the administrative director of the Transplant Institute. And thank you for joining. The objectives for this presentation will be to outline the imperatives in solid organ transplantation as it pertains to organizational structures, to share one model for integration, discuss the benefits and the challenges that come along with that, and also outline future directions. So the discipline of transplantation is very unique in the sense that it addresses the care continuum for patients with end-stage organ failure, and hence it demands significant degree of collaboration between providers and institutions throughout the phases of care and care transitions, and also coordination of care to assure the best outcomes. Staff work in teams, and this is good for patients, but also obligatory to have the best outcomes. We also work in a very complex regulatory environment, more so than any other specialty. There is a heavy focus on quality and outcomes, and also a great degree of legislative and regulatory components and policies that we have to be compliant with. And furthermore, we have evolved into bundle payments over the last 2 decades, to where there is significant risk involved with the payment model. And the finances are often complex, especially when it pertains to private payers with different models and regulatory agencies. So the emphasis over the years has been in clinical medicine over clinical and technical excellence. And this has evolved with an emphasis on cost containment and the more recent language pertaining to value and value-based payments. We have lived in this paradigm in transplantation, and the bundle payment model brought with it an ecosystem that we're all very familiar with as how we tie up with physicians, hospitals, and patients and their families and their care transitions. So the Henry Ford Transplant Institute began about 50 years ago, and I only shared this to show that there is a lot of similarities between our own organizations. We started with kidney transplant in 1969 and evolved to all solid organs with heart, liver, lung, kidney, pancreas, and intestine. We also had a similar structure to many, with academic departments and divisions leading those clinical programs, often with a heavy emphasis on surgery. And the finances were siloed between the divisions and the departments as well. Clearly not a framework that allowed for a good evolution and growth, and the leadership in the programs were always facing challenges of how to expand, and it was not clear what the roadmap would be for that expansion. So this is where the language and the idea of an institute came about. In essence, what we thought that we functioned with a silo mentality between the hospital and the departments. There was no unifying theme or culture. There was significant lack of financial transparency. between the departments and between clinical departments and hospitals. And also there was a limited understanding of how revenues came in, how they were accounted for, and what the funds flow were like, and also a very poor understanding of the CMS organ acquisition cost center and how that functioned and how the physicians and providers as well as the institution could work together with that. There was strategic misalignment between business units. The incentives led people to have opposing directions and opposing priorities, did not align. There was no investments in the needed resources to expand and deliver the best services. There was no quality or regulatory oversight. As a matter of fact, physicians typically challenged those requirements. And there was no activity in relation to outreach and marketing to make sure that your local market and regional market is aware of your existence, what services you provided, and make sure they understand you're an extension of their service. So we proposed a model. We turned it the Institute, and there are many terminologies out there. We proposed it to allow for better financing of our operations and contracting, and also to align the strategies and to provide the proper staffing and the resources needed to execute on those strategies. We propose to break down the silos and create a common culture and purpose and engage everyone in teams to achieve superior clinical services and innovate in how we deliver those services. So we also propose to start and expand an outreach operation, which became a business unit by itself with 21 satellite clinics at this time. We also propose to expand the philanthropic efforts and the development efforts to our communities and appreciative patients, and also engage patients and families in the care experience, not only to assure good service, but also good long-term outcomes and how we design care. And also we propose to establish a shared governance where all stakeholders will be represented and have a say in the management, operations, and strategy of the enterprise. And now I'll pass it on to Bob.
So this picture kind of graphically depicts some of the disjointed communications that those of us live with on a daily basis. With the multidisciplinary medical and surgical approaches needed in transplantation, you often get some creative communications. So as we imprinted the Institute design on the process, that kind of brought together a body, a liaison to other departments to communicate better, to foster a better relationship with some of the ancillary services and supporting departments. As we approached administration, this goes back to like circa 2006, there was a deep dive done on the sources of revenues to the hospital, and it was determined that about 12% of the gross revenue that went to the hospital is coming from the transplant patient and the transplant population, which got a lot of attention from administration. As administration kind of viewed it, we were running 5 different products, 5 different departments that each had various needs on the left-hand side there, and the departments got siloed. Each was viewed independently, and there was a need to kind of create a synergistic approach, and with the Institute, it allows us to cross departments to get a common financial approach, a common resource approach, to develop standardized quality across the whole product line, including all 5 different business units. This is kind of a depiction of the first attempt to put together. There's certainly a need for an oversight or a steering committee of a transplant process. There's also a need for an advisory group if you're going to get into the philanthropic part of the business, and also a need for quality. Very important for transplant programs, and it's part of our regulatory processes. So we developed a work group to look at some of the administrative processes, and then also a clinical staff forum that kind of grouped together the clinical issues, how to work with patients, how to set up the flows through the process. Early on, it was a critical decision that you needed, and we needed to get the key decision makers at the table to talk about processes and how to set up a better evaluation of our transplant program, and recognizing that this group of decision makers would be the oversight group that we could provide accountability to. And it included key members of all parts of the organization, from the medical group, CEO, we have an employed medical group here, the hospital CEO, chairs of the clinical areas, and also nursing. And every C, fill in the blank O, was invited to this group. Once they were processed and attended and saw the impact of the revenue on the hospital financial portfolio, it got their attention, as we said. The Transplant Center then was created. A separate cost center was developed for pragmatic and accountability purposes. It included the surgeons, it included the support staff, including the transplant coordinators, the technical and ancillary services for insurance verification, the quality support staff, and it also included the external entity contracts for our OPO. We also included some of the physicians in there under a subsidy model, and that included the hepatologists, the thoracic medical physicians, and subsequently we have evolved to where the hepatologists and the transplant nephrologists have moved up into the transplant cost center. Very crucial to our approach is the investment in decision support analytics. To be able to track the financial activity of each transplant patient, it allowed us to push our agendas to develop more strategic initiatives for growth. It allowed us to track populations that we're seeing. And it enabled us to even get into the halo effect that the transplant business brings in to a particular transplant center, where you may not be transplanting people, but they're coming to you because of the transplant business. And very crucial to this, we were able to segregate revenues and costs to provide detailed information per organ, and also to demonstrate to the administration contributions to their financial operations. One of the important strategies of the Institute was to develop a strong communications effort. It is important, you cannot stress it over and over and over and over again, to communicate with everyone involved, especially when you're in an institute design where you do not have direct control, direct authority over some. So we strategically involve leadership in all of our communications, the goals, the strategies, the designs of the Institute. We created physician forums for referring physicians, and also for physicians that had some interest in supporting our transplant patients. We have program directors assigned for each of the organ areas, and we provide focused retreats that support clinical education, and also that for the support staff, how we can improve operations. We have yearly retreats now where we pull apart and address different topics. Could be emotional intelligence, it could be our goals for the next year, something personal, something from an aggregate corporate level. And we also invite key system employees that aren't in the transplant program to participate in those.
Thank you, Bob. So one of the key things about the Transplant Institute and its formation, besides the extensive communications and design and getting feedback, is ascertaining there is a great deal of transparency and effective communications with all parties and all business units and entities. And also develop a set of aspirational goals so when people see a new design, that this is not just yet another buzzword or an activity that's going to evaporate in 5 years. It needs to have shared initiatives, which Bob mentioned about the retreats, but also these could be built through focused activities as well within departments and leadership forums. There was significant empowerment and recognition of leaders at different levels. Many people want to take credit for a lot of the work, and we had to make sure that the senior and mid-level leadership and program directors all feel that they're part of that winning activity, and they take credit for that. We also had to create common vision and goals and behaviors. So we engaged in a lot of that work early on, where the staff developed pledges and goals, SWOT activities, and agreed upon behaviors. And when we say staff, we talk about frontline medical assistants to nursing, mid-level providers, all the way to the chiefs of services. We also had to promise and deliver on extensive resourcing and listen a lot. Many people will have ideas, many will have reservations and pushbacks. So there was a fair amount of navigation to be had. And therefore, we felt that we had to hold regular events as teams where there is a mutual communication, mutual learning were always taking place. So in addition to the original pledge 15 years ago, our teams went back and engaged 2 years ago in a new vision statement. And this is where you see the teams coming together and emphasizing things that they feel strongly about. A certain level of passion relates to patients and families, sense of innovation, providing the best quality care, and also emphasizing an environment of compassion and hope. And these are things that the staff came up with, and the statement ultimately got voted on. And this emphasizes that the Institute is not just an administrative structure. People view this as with a sense of ownership, and that's also, they are part of that. So when we look back and say, what are the benefits of creating a structure like this? Clearly, growth of the clinical programs were the most visible. We're near a doubling of the clinical volumes from the initial inception 15 years ago. In addition, we have developed new programs that were sponsored and supported actively. There were many innovations that had a lot that went behind them, whether these were innovations in research or the ex vivo liver pump machine or starting an intestinal multivisceral program and so on and so forth. They were matched with revenues increases that made leadership understand that frontline investment pays off. There was much better understanding optimization of finances. We have expanded and improved our contracting business unit. We have a very robust quality improvement and regulatory compliance, which piggybacked with the hospital's main office for quality improvement, which allowed certain depths and bigger scope and scale. We expanded our outreach operations, which at that time had only 3 clinics. Now we are out to 21 clinics throughout the state. And again, all these involve capital investments and manpower investments, which an institute structure would permit. We have significant visibility via marketing and public relations, and the name brand in the local market became the most visible and recognized name brand. And that type of collaborative model expanded into the research arena with the creation of a transplant research collaborative where you combine multiple disciplines and they collaborate on research projects, much in the way they deliver clinical care. And we've also engaged patients and ambassadors in patient-centered activity, and we created what we call the transplant living community, which also piggybacks into patient, family, and advisory councils that help us kind of guide and shape care in a way they best understand it, accept it, and blend with it so it's shaped around their needs. The organizational structure is something that will always evolve. When you set up an institute or a service line, you got to design it to be very functional. Ours combines the hospital and the medical practice with an employed practice into a specialty steering committee to which we report. We also created the role of an associate medical director with emphasis on certain functions. Here will be medical services and the outreach, and each person will have an area of responsibility, and we all combine together in the aggregated functions of an institute. And these have to be adapted to the history and the culture that you have and what kind of functions you're trying to establish in your own organization. An outcome of an institute or a service line as well is that you will have to create a matrix of some sort of how you will relate to your academic departments, if you have those in your institution. So here we divided with the CEO's assistants our functions, whether it's operations, quality, strategy, education research, facility management, and so on. And we decided who's the primary owner of that particular component and where do we collaborate with each other. So the Institute, for example, oversees the clinical and financial operations, but when it comes to research, we collaborate with departments, and when it comes to salary management, incentive plans, and recruitment, we collaborate with the departments as well. So reflecting back on the formation of the Institute and the journey, which I suspect will be common for most institutions who embark on this, is that it has been a tremendous success for us. Significant growth in volume, significant goodwill came out of that, and we created a collaborative workspace that is being emulated for other service lines now. However, change will be difficult, and I think that the work of leadership will not stop, will continue, and I think change management is at the core of this, and this is where you have to elevate the conversation to more visionary work. There will be some conflicts, and we will have to manage those. There will be perceptions of hidden agendas, and these also have to be managed, especially when it comes to financial bottom lines and scope of power. We had to engage all bloodlines, whether it's management, finance, hospital, medical practice, corporate. We have to get comfortable with engaging the different bloodlines and engage them all in visionary thinking. A new collaborative leadership style needs to be guiding and steering this kind of activity. It cannot be positional, it cannot be territorial, and it cannot be one of those pace-fitting, Napoleonic style. And the senior leadership support is critical, especially when it comes to having this currency that will allow you to negotiate with departments. And at some level, departments will have to have some accountabilities, because if the departments steer in opposite direction, it will derail the institute. And once this happens, it's very difficult to pick up the pieces. So going forward, I find that refinement and governance will always be a critical component of who leads what, who interacts with what, and how to continue the connectivities. We're going to have to continue designing systems of care, especially in a value-based care environment. Being in an institute or a service line truly helps you understand the true cost and the pathway for the care that you provide, and how do you attach value, and how do you manage your cost, and especially how you standardize the care pathways, so that you understand your bottom line better and how you navigate the outliers. Modeling and innovation is core and center to this work, and this is allowed also in an institute framework. We have to engage patients and families much better and continuously do so, because ultimately the final outcomes for these patients will depend on them and their caregivers and how they engage in this long-term activity, and also engage with our referring communities and primary care and specialty referring physicians as they engage in the long-term care for those patients, or even optimizing the referral at the right time. Ultimately, the formation of an institute engages people from different backgrounds, different departments, patients, and their care providers. It boils down to really to people. And the better we figure out how to manage people, empower them, engage them, have them see a greater vision bigger than themselves and then be part of it, so we all win together, this will lead to the success of an institute, and our experience has gone in that direction as well. And I would like to end this here, and this is our contact information should people have any additional questions, and we'll open it for questions. Thank you so much.
Our thanks to Dr. Abouljoud and Mr. Hawkins for their fantastic insight, and our thanks to you for taking the time to view this valuable program. If you have any questions for our presenters, we'll be sure to include their contact information on our website at organdonationalliance.org.